go through these. So, and again, these will be a great study resource for you when we're getting ready to take the exam. It's got all this good information about fluid volume excess versus fluid volume deficit. And again, a lot of this we talked about when we learned assessment. These are a lot of the examples that we used when we went through head-to-toe assessment. So a lot of it should look familiar, but just now you're specifically more thinking about that fluid status for our patient. Okay, so for our first scenario, the information that you have there is dry mucous membranes, tachycardia, low urine output, elevated BUN, full range of motion, WBCs within normal limits, poor skin turgor, and hypotension. Right? So, who wants to tell me what they identified? Does this look like fluid volume deficit or fluid volume excess? Do you have any volunteers? Casey?
Fluid volume deficit?
Yeah, so based on your readings and your notes and all that information, this is going to be a fluid volume deficit patient. So for whatever reason, either they're not taking a lot in, or maybe medications are making them excrete more, that balances off, they're eliminating more than they're taking in. Okay, so for whatever reason, they're in fluid volume deficit. Okay, and then rather than identifying the relevant findings, it'll be quicker to just identify what does not belong, what has nothing to do with fluid volume deficit. Is there anybody who wants to tell me what those were? Tabitha, what'd you get?
The full range of motion doesn't matter.
Yep.
The white blood cell count doesn't matter.
Yeah, so those two pieces of data are just distractors, nothing to do with if they're in excess or deficit. So that white blood cell count we know means infection, or if it's too low, they're at risk for infection. They can't defend themselves against infection. We'll talk more about that when we get to the section, unit 5. Okay, so those two don't belong. And then what is a priority intervention for this patient? Sophie?
Encourage fluid intake and monitor items.
Perfect. Okay, so encourage fluid intake. So depending on what's going on, maybe it'll be oral intake, just drink fluids, drink water to try to rebalance. Definitely monitor I&O, and then depending on how bad it is and what the patient's situation is, then we're looking at intravenous fluid. So we're gonna be given some intravenous fluid replacement for this patient. And then BUN, so depending on what resource you looked at, you could have seen different numbers. Labs are funny like that, but the range I want you to know is 10 to 20. Okay, so a normal BUN should be 10 to 20. Okay, so that's a supporting lab, because if it's elevated, it means that their body composition is very concentrated. Okay, so we'll look more once we get to fluid volume excess. Their BUN could be low, abnormally low. Okay, so an elevated BUN, so that stands for blood, urea, nitrogen. So it's just waste products that are in the plasma. And if you take a blood sample and there's less plasma, which is the fluid part of the blood, than there should be, then the ratios are gonna be off. So the fluids are more concentrated. Okay, so as we go and draw that blood sample for you and I, there would be much more fluid and plasma in that sample, so the BUN is gonna be more dilute, how it's supposed to be. If there's less plasma, less watery substance, the BUN is gonna be more concentrated, so the number is gonna be higher. Okay, so the BUN tells us hydration status. It also tells us kidney function. Okay, next week we'll talk a little bit more about BUN and creatinine also. So those are our two labs. They show us fluid status and then kidney function as well. All right, so that was good. All right, our patient number 2 then. We've got edema, crackles, weight gain, a low hemoglobin, ANO times 3, history of cataracts, bounding pulse, and shortness of breath. Okay, so who wants to tell me, did you identify a deficit or an excess? Addie?
Excess.
Yeah, so that's an excess. Okay, so the edema means swelling, right? So usually it starts in their lower extremities, but just depending on what's going on, it could be in any of their extremities. Okay, crackles, that's lung sounds, right? So our fluid volume is determined by our circulatory system, right? And our circulatory system runs through our lungs, right? So from our left ventricle, our from our right ventricle, all of our fluid volume goes into our lungs, and then from there it comes around to our left atria, and then out to the rest of our body. So if we're backed up and if we're overloaded, it's gonna show everywhere, not just in our vascular system, but it's gonna back up into our pulmonary system. So you'll hear those crackles, because that's fluid that the body just has too much of, it can't push through, so you'll hear those crackles. Okay, and then weight gain, like we said, if you think of some experiences you may not realize, but if you think of like NCLEX perfect world, that we're weighing our patient correctly at the same time each day, a weight gain or weight loss is the most accurate indicator of fluid volume changes. Okay, so again, they're retaining fluid, they're not excreting it. Fluid has weight to it, right? So you're gonna see an increase in weight. Okay, so our heart failure patients, part of their teaching when they go home is to weigh themselves every day. And if they notice more than like a 2-pound weight gain in a day, or like 5 pounds over several days, they're supposed to call their provider. Maybe they need their medications readjusted. Okay, and then low hemoglobin. So what's hemoglobin? Who can tell me what hemoglobin is? We talked about it a little bit yesterday. Tiara, can you tell me what hemoglobin is?
The blood count.
It's part of the blood count. It's part of your red blood cells, and the hemoglobin is the part that carries oxygen. Okay, so usually they all go together, red count, hemoglobin, and hematocrit. Hematocrit's a percentage by volume of the red blood cells, so they usually all go together. If one's high, they're all high. If one's low, they're all low. They usually go together. Okay, so just like with the elevated BUN for dehydration or deficit, now here there's too much plasma, there's too much water. So if we go to draw that blood sample compared to the total volume, that hemoglobin is gonna be low. So it's not necessarily that they're anemic, usually it's like a false low is what we call it. So once we get their fluid volume stabilized and normalized, their hemoglobin then usually normalizes. Okay, so it's just based on the sample that we draw. There's much more plasma or watery substance than those little cells, the red blood cells, all the different cells. So it could be a low hemoglobin. Okay, hemoglobin for your patient, it depends, right? I usually just try to remember the number 15 and then around there, give or take, right? Because there's a range for men, a range for women. It's what, 12 to 16 and 14 to 18 for men and women. So I kind of remember just around 15. Okay, so it would be lower than that. Okay, and then the ANO times 3 and the cataracts, right? Those are just distractors. That doesn't have anything to do with fluid volume status. Okay, and then the bounding pulse, again, your pulse and your blood pressure is based on your fluid volume. So if we have so much, that pulse is going to be bounding and very strong. And then the shortness of breath goes back to how our blood goes through our lungs as well, and it backs up. So that's kind of related to the crackles. Okay, so they're overloaded. So if we have fluid taking the place in our alveoli, that's where gas exchange occurs. If there's fluid, that gas exchange can't occur, the oxygen and the CO2, so they're gonna have some shortness of breath. All right, and then scenario 3, who wants to tell me what you identified? Mary, what did you identify for scenario 3?
FBD.
FVD, okay, so fluid volume deficit. Okay, good. And then what is the data that does not belong, that doesn't have anything to do with the fluid volume deficit for scenario 3? Anybody want to tell me? Matt, Virginia? Yeah, the BMI. Okay, so it's just BMI is BMI, right? It's not necessarily related to fluid status, and it's normal anyway. And then there's one other one.
INR.
Yeah, that INR. So that's for Coumadin. So if this was a patient who was on warfarin or Coumadin, that would be good. That would be a therapeutic range between 2 and 3. Okay, so those two are distractors. But the rest of these are all things that you'll see if your patient is at a fluid volume deficit. So again, they just don't have the volume, so that blood pressure is going to be lower than normal, so that 88/54. We're going to see tachycardia again. Okay, tachycardia, I didn't have it here, I guess. But tachycardia is one that you'll see in excess or deficit for different reasons. Okay, so you'll see it in excess, it goes with the high blood pressure because your body is working hard to move that fluid. You'll see it in deficit, even though the blood pressure is lower, because your body knows that it's not getting perfused because there's just not enough volume, everything is low. So that's like a defense mechanism that your body's gonna kick in and speed up your heart rate to try to get your all of your organs perfused. Okay, so you'll see tachycardia in both, but it's for different reasons. Okay, and then the cool, clammy skin goes with the lack of perfusion, so we just don't have the volume. So your body is gonna protectively make sure what you do have goes to your heart, to your brain, to your kidneys, to those vital organs. So, you know, your hands and your feet, not as necessary, so they're not gonna be perfused as well. So you could see the cool, clammy skin. Okay, and then decreased urine output goes along with that. Remember, your urine comes from your blood. So your blood goes to your kidneys decide what's gonna stay, what's gonna go. You just don't have enough to have a copious urine output. And again, it's a defense mechanism. Your body is not getting perfused, so your kidneys are gonna retain even more than they would, just to try to keep that volume in your body. Okay, and then increased H&H then, that's hemoglobin and hematocrit, so with the red blood cells. So again, just like we said for fluid volume excess, they have low hemoglobin because our blood is more dilute. With fluid volume deficit, everything is more concentrated, so it's gonna seem like the ratio is off and those numbers are very high. Doesn't necessarily mean they're anemic. Once we get them normalized and back in fluid balance, that should stabilize, unless they do have an underlying anemia of some type. Okay, and then our last one, who wants to tell me if we've got deficit or excess here? Carolyn? 4.
FVE.
Yeah, FVE, fluid volume excess again, okay? And then what are the signs and symptoms or the data that does not belong? Who wants to tell me that? Sienna?
Strong pushes and pulls until those 200,000.
Yep, strong pushes and pulls, okay, that's a normal part of assessment. Not necessarily gonna be different with the fluid volume excess or deficit. And then our platelets, those are our part of our complete blood count that helps us to clot. And those are within that 150,000 to 400,000 range, so nothing doing with that. Okay, so again, with excess, we're gonna see the edema, we're gonna see the crackles in the lungs, we're gonna see the elevated blood pressure, we're gonna see that weight gain, we're gonna see that lower H&H again, just because compared to the rest of the fluid status, it's more dilute. And then if you remember JVD back from assessment is jugular venous distension. So again, the circulatory system is overloaded. It goes with bounding pulses and tachycardia and high blood pressure. You may see their jugular vein like actually distended out like this. Has anybody ever seen that in real life? I've never really seen it in real life. But that would be really bad. That'd be a critical situation. All right, good job. Go ahead and pass out the next activity. This video. All right, any questions about any of that vocabulary? Okay. All right, so first we were seeing if we were excess or deficit in fluids, and now we're being lab detectives to start trying to figure out and read these lab values. Okay, so looking at that patient A, Na means what? Is sodium. So that's one of our minerals, one of our micronutrients, right? So it doesn't supply calories or anything, but we need an adequate intake to make use of the carbs, fats, proteins that we do eat. Sodium, just like fat in the American diet, is easy to get, right? It's in everything. Like, we have to work hard to avoid sodium, okay? Sodium is specifically related to the water content in your body. So where sodium goes, water follows, okay? So we said that's sodium. What's our normal range of sodium? Anybody find that?
135 to 130.
Yeah, 135 to 145, and it's milliequivalents per liter, 135 to 145. So we're below that range, so this would be called what? Yeah, hyponatremia. Okay, so hypo, and then the Na, and then tremia means in the blood. So not enough sodium in the blood, hyponatremia. Okay, so when our sodium is low, going back to that concentration and compared to the rest of the body, Usually, when our sodium is low, our patient is fluid overloaded. They usually go together. So the opposite of that is true. So with patient C, when the sodium is high, usually they're dehydrated. Okay, so the sodium and the water content will usually go together. Potassium, the next one that we're gonna talk about, is a little bit different. It's not closely related to your water content, it kind of does its own thing. Okay, any electrolyte that we have in our body, if we're not in the normal range, we're looking at, in general, the same type of symptoms. Okay, so they're responsible for heart function. Okay, so even if you don't have to remember too fast, too slow, or what specific arrhythmia, you could have an arrhythmia, so an abnormal heart rate. Okay, also muscle strength, muscle contraction. Okay, so you're gonna see some type of abnormality in the way that our musculoskeletal system works. Okay, so heart function and musculoskeletal function are usually related with our electrolytes. Okay, so which were the 4 that you guys picked out that go with hyponatremia? Anybody think they got those 4? Addie, what did you come up with?
Cramps, confusion, headache, and nausea.
Yeah, perfect. Okay, so the confusion, the headache, the nausea, and then the muscle cramps, okay, are all the ones that would go with that. Okay. All right, so for this patient, what is gonna be an intervention?
I put restrict isonos.
Your strict isonos? Yeah, so for this one, like since I told you that it usually is gonna go with fluid overload, the sodium is too low, we're gonna restrict water. So if you've ever seen a patient who everybody gets a water pitcher, but this patient has Powerade or Gatorade come up on their tray, that's because they need the sodium. Like most patients have too much, okay? But if for some crazy situation, you have a hyponatremic patient, which is not very common, they need the sodium now. Okay, so we're not gonna give them water because that's gonna further dilute them and further drop down their sodium. We're gonna let them have the Fritos, we're gonna let them have the good tasting food, and we're gonna be giving them something with electrolytes to boost them up, okay? So possible fluid restriction, and then maybe depending on what's going on, we might give like a sodium infusion, but that's very dangerous, so we kind of have to watch that. We'd usually be more in a critical care situation if we're gonna try to replace sodium. Usually we're just gonna restrict the free water, have them eat the things that have high sodium, and just kind of watch and monitor.
Did you give like IV fluids, like saline? For that?
Yeah, you could give sodium chloride, normal saline, just depends on what else is going on with the patient, but you could. Okay. All right, good. All right, so moving down to the next one. So what is K? K is potassium. Okay, and what's our normal range for potassium? Should be 3.5 to 5.1. Again, you might see slightly different. I'm sorry about that. 3.5 to 5.1 is a pretty standard range that we look at. Okay, so if we're 2.9, patient B is gonna be what? Hypokalemic. Yep, hypokalemic or hypokalemia for this one. Okay, so they're on the low end. Okay, so what are we gonna see? What are our relevant sign or symptom that's gonna go with patient B? Do you think we got it?
Weakness, irregular heart rhythm, hypertension, and fatigue.
We're close, okay? Weakness, irregular heart rhythm, and fatigue, yes, all go together. Okay, but the potassium is not really related to the fluid volume status or anything. So unless something else is going on, we wouldn't necessarily see their blood pressure go up with a low potassium. Okay, but we're gonna see the weakness, the irregular heart rhythm, the fatigue, and then a related sign or symptom is the diarrhea for the past 3 days because they're excreting too much, okay? So that one could be a related sign or symptom. Now, if we don't resolve it and their potassium is like chronically low, a side effect is constipation, okay? So that's kind of tricky, okay? But as a related sign or symptom is a cause, so anytime your patient is vomiting or having really bad diarrhea, we worry about hypovolemia or fluid volume deficit, and we worry about their electrolytes dropping down as well, okay? All right, so that was good for that one. And so for this one, what is the priority intervention? Yeah, they need some type of potassium replacement. So depending on what's going on, maybe we're giving them the capsules that they can swallow, or maybe now we're doing IV replacement. Okay, so we can have like a bag of saline and have it mixed with potassium, and they can be getting saline with potassium like continuously 24 hours, or potassium. You'll see, you'll hear a nurse talk about they have K riders to hang. They have 4 K riders due for my patient. That's just a little piggyback of potassium that we hook up, and they have a little bag that goes in. Okay, never IV push. Potassium never comes IV push because that would be lethal for our patient. Okay, so we're going to replace the potassium, either oral or IV, piggyback, or a primary drip. Okay, good. All right, patient C then. Okay, so we already said that is sodium. We said 135 to 145. So this 150, we would call that what? Yeah, hypernatremia. Okay, so too much sodium. Okay, so now this patient that has too much sodium, we're kind of thinking of our fluid volume deficit patient. So everything is more concentrated than it should be. The sodium levels are high. This patient may be a little bit dehydrated. Okay, so what are the signs and symptoms that go with that? Anyone tell me the 4?
Thirst, dry mucous membranes, lethargy, and restlessness.
Yeah. Okay, so thirst, dry mucous membranes, lethargy, and restlessness. Okay, so you've got too much sodium, too salty, so they're kind of going to be in a dehydrated or fluid deficit state. Okay, so for this patient, what are we going to do to help get them back?
Give them fluid.
Yeah, we're going to give them IV fluids, and then there's 3 types of fluids that we're going to talk about. Okay, so you've got isotonic fluids, which means that they're the same concentration of our plasma, and we said our primary one to know is 0.9% sodium chloride or normal saline or NS. Okay, so that's an isotonic solution. Okay, so we could give that to replace, but again, it's got the sodium in it, so we would more likely then choose a hypotonic solution. So it's going to give them the fluid, but it's not going to give them as much sodium. Hypotonic. And does anybody see from your PowerPoints what's the example of the hypotonic solution? It's less concentrated, so it's called half normal saline or 0.45%. So it's less concentrated, it's got half as much sodium chloride compared to just like the watery part of it. So 0.45 or half normal saline. It's a hypotonic solution, so it's gonna give them the fluid but not the sodium, so hopefully it's gonna balance things out. Okay, and then our example of hypertonic, which I've never given, it's very uncommon, we don't give it often, just because it can cause such a strong change in the fluids in our body. But a hypertonic is going to be more concentrated, and the example in your PowerPoints is 3% sodium chloride. 3% sodium chloride. Okay, so it's got more than 3 times as much sodium concentration compared to what's already in our body. Okay, so only in like severe critical situations would you see that. But those are just some good examples to kind of think about isotonic, hypotonic, and hypertonic. Okay, so it's just talking about like the concentration of those electrolytes in the fluid. Okay, so for this patient, we would likely give a hypotonic, half normal saline or 0.45 is what we would give. All right, and then our last one, we're back to the potassium again. So this potassium of 6.2 would be called what?
Hyperkalemia.
Yeah, hyperkalemia, and then what are the 3 signs and symptoms that go along with hyperkalemia? Yeah, muscle weakness again. Okay, ECG changes is just another way of saying irregular heart rhythm or an arrhythmia of some type. An ECG, electrocardiogram, is when we put all those electrodes on and we take an image of the heart and it shows the rhythm there. Same thing, now that you're in the hospital, you have patients with telemetry and they have a continuous monitoring of their heart rhythm. Okay, so ECG is just monitoring the heart rhythm, the heart rate. Okay, so in the hospital this week, if you have a patient who's on telemetry, before you go in and see them and do vitals, you wanna look at the monitor and see, this is my patient's exact heart rate, exact rhythm right now. So that's what I'm gonna be looking for when I go in then and do my apical and do my pulses. A lot of them also will be hooked up to a continuous pulse ox, and you'll see that on the monitor too. So you can see, oh, right now my patient's 84. I better go in there and see, you know, their oxygen's off or something. Okay, so those two pieces of data are really nice to have even before you go in and see your patient. All right, so muscle weakness, ECG changes, and then paralysis is another one. I had paresthesias on here, which means numbness and tingling, like weakness of the extremities, but your ATI book says specifically paralysis, so I thought I would put what you have just so it's not tricky for you. So paralysis would be like even more extreme to the point where now they like can't move their extremities. Okay, so like we said, the electrolytes are responsible for muscle contraction, heart contraction, all of that. So if any of them are off, those are like the category of signs and symptoms that we're gonna see. All right, so for this patient with the super high potassium, what are we gonna do? Okay, so for sure, if they're not already, they need to be put on a heart monitor. Okay, so if they have a potassium that's out of the normal range, they need to be put on telemetry if they're not already, so that we can identify if they go into an abnormal rhythm. Okay, so most of our patients should be in normal sinus rhythm, atria and ventricles within 60 to 100. Over the next few semesters, you'll learn about all the different crazy rhythms, what causes that and what that means. Okay, but for now, just know if their potassium is out of the normal range, they need to be on a heart monitor, okay? Some other things that we would give, this is kind of high level, so I'm not gonna test you on this, but we would give calcium gluconate IV to protect their heart. We would give some insulin. You already know that insulin swoops up all the glucose out of the bloodstream and takes it into the cells where it needs to be. Insulin also will gobble up the extra potassium and take it out of the bloodstream into the cells. Okay, so we don't have hyperkalemia in our bloodstream anymore. Takes it into the cells where the cell can then use it and metabolize it. Also, which you may have guessed, we would give some diuretics. Depending on what else is going on, as long as they're not like kidney failure, fluid volume deficit somehow along with that, we would give some diuretics to help get that extra potassium out. And then there's a specific drug that you read about, and that's in the PowerPoint, called polystyrene sulfonate. And it's like a little molasses looking liquid. You may have seen your patients take this on their unit, and they drink that down, and it condenses and collects all the extra potassium in their GI system, and they eliminate it out in their stool. Okay, so there's like a cocktail, a combination of things that we give to protect the heart, because we know it can cause the arrhythmias, that could be lethal, and then to help get that extra potassium out. All right, any questions about that activity? So again, these are just good study guides for you for once we get to exam time. Okay, and then we have another little case study. This one's just got some information and then some multiple choice questions, and then we'll do our Kahoot. Okay. All right, I think everybody's done. So let's go through this here. So we have a patient, they have a history of high blood pressure, which we've been talking about a lot. And then this one also has chronic kidney disease stage 3. So those are those patients that are eventually gonna end up on dialysis, so their kidneys aren't working correctly. So you'll see a lot of fluid and electrolyte imbalances with these patients. All right, and then the medications, lisinopril we know is an ACE inhibitor for blood pressure. And then hydrochlorothiazide is a new one. It's kind of like Lasix, it's a diuretic, only it's a little bit more of a mild diuretic. Okay, so it's gonna help them pee. Because they have the kidney disease, it's kind of helping their kidneys do what they're supposed to do. Okay? So this patient's been having 3 days of vomiting, diarrhea due to a stomach bug. She's weak, she's dizzy, she's thirsty. Assessment findings, she's got dry mucous membranes, poor skin turgor, that blood pressure is on the low side, she's got some tachycardia, and then urine output of 20 mLs per hour. Okay, so if you we're like, what does that mean? You probably looked it up and you read that minimum should be 30 mLs per hour. So this is like real bad, critical care patient, like we need to address this. Okay, so that's very low. A little bit of a prelude into Tuesday's lecture when we're gonna go over elimination. Okay, and then you've got some lab results here. Our sodium is elevated, so they're hypernatremic. Potassium is low though, so they're hypokalemic. BUN and creatinine are high, so that kind of goes along with the dehydration there. All right, so they're admitted then with suspected dehydration and electrolyte imbalance. The provider orders some IV fluid, some electrolyte replacement. You must assess fluid status, interpret the lab values, and then implement appropriate interventions. All right, so number one, based on Mrs. Carter's assessment findings, which condition is most likely? Do we have fluid volume overload, fluid volume deficit, or two things that we haven't really even talked about at all yet, okay? So is it gonna be A or B? What did you guys get?
B.
Yeah, that's B. It said she's admitted with dehydration, okay? So dehydration is the medical term, and then our nursing diagnosis is the fluid volume deficit. Okay, third spacing, you'll talk more about eventually. Has to do with how they're able to keep their fluids where they're supposed to be. So they're not in the vascular system, they're not in the cells or the interstitial system. They're seeping out into the tissues. And usually that has to do with their protein intake. They're not getting enough protein. Protein is one of the things that helps keep our fluids where they're supposed to be. So if you see a patient whose albumin and protein levels are low, you'll see this third spacing, fluids leaking out where they're not supposed to be. And then SIADH, it will be once you get into endocrine stuff, it's syndrome of inappropriate antidiuretic hormone. So that's for later on in your program, right? Which assessment finding is most concerning then and requires immediate intervention is gonna be what, Carolyn?
C?
Yeah, C is gonna be that urine output of 20, okay? So like I just told you, it needs to be at least 30. If they're not putting out more than that, then that's like really bad. So all the other things, signs and symptoms, thirst, dry mucous membranes, heart rate, like you could see that way ahead of the time before it catches up with the rest of their system and their output is so low. So if you see all these things and the urine output, that means that they've progressed so bad that they like really need some intervention. Okay, again, that's a little bit of a prelude for next week's stuff. All right, and then how would you interpret their data, which is the only one that is correct about the scenario that you read?
B?
Yeah, it's B, they're hypernatremic with that sodium of 150 above the 145. And then which symptoms, select all that apply, are consistent with the potassium level? Okay, and there's 3 of them. What did you guys come up with? Gabby, you look like you want to answer.
A, B, and D.
Yeah, A, B, and D, okay? So you're gonna see this repetitive stuff, okay? Muscle weakness, the dysrhythmia is just another way of saying arrhythmia or ECG changes, and then the fatigue, muscle weakness type stuff. Okay, which IV fluid is most appropriate to start initially? And really, there could be 2 potential answers for this one. So you may have put A, or you may have put C. Okay, so either way, just kind of depends on what's going on with their sodium being high. We might do the 0.45, but since it is directly related to the fluid volume deficit as well, once we just get some fluids in their system, it should stabilize. So either one of those really wouldn't be wrong. It's just gonna depend on the provider's preference and what's available, because sometimes one would be available and one's not, so we would choose one or the other, okay? And then, based on all the information, what's the priority intervention? Krista, what'd you get? B. Yeah, just B, monitor intake and output. They're already dehydrated, so we're not gonna restrict. It's not time to make sure they're getting up and walking, right? Because they're having those abnormal labs and weakness and all of that, and the possible dysrhythmia. And then we're not gonna give diuretics because that's further gonna dehydrate them. So that just leaves B. All right, and then based on what we've been talking about then, which of the following indicates improvement in their condition? Who got that one? Okay. Yeah, it's gonna be A, so that urine output is gonna increase to at least 40, okay? We don't want their blood pressure to drop, we don't want their heart rate to go up too high, we don't want their sodium to be even higher. Okay, and then she's gonna ask you, why is she receiving potassium? What's the best response for that? Jordan? Yeah, it's gonna be B. It replaces what your body lost and helps your muscles and heart function properly. All right, let's do this Kahoot, and then I'll tell you what med to do.
I was gonna say, I don't know what med to put on there. Everybody in that wants to be in? Yeah, that should be. So you don't always notice that word, but when they order labs, they order a serum potassium or a serum sodium or whatever it might be. And when we draw labs, we're drawing fluid from the intravascular space. So you read about the 3 places where fluids are. So they're intracellular, so in all the billions of cells that we're made of, there's fluid that's intracellular. There's fluid that's intravascular in our vessels themselves. That's where we pull for labs. And then interstitial is gonna be in between. So it's not just like dry in between the cells and the vessels, there's also fluid, so interstitial. Okay, and then your body can move fluid between vessels, cells, interstitial space as it decides that your body needs to have the fluid moved. Okay, so serum lab, like if they order a serum potassium, that's just gonna be from the vascular space. Yeah, so plasma is the watery substance. So we have all of our cells in there, and then plasma contains nutrients carried to our tissues and then carries waste away from our cells and tissues. Yeah, so water is necessary. We need a whole lot of water, about just like we need 2,000 calories, give or take. We need about 2,000 milliliters of water, 2 liters every day, give or take. So if your patient's having some issues and you just do like a simple food diary and see that they're not drinking any water, just swapping that out, they can see a lot of health improvements. Okay, pretty good. So hypernatremia means their sodium's too high. That's that dehydration patient, so their fluids are gonna be too concentrated.
hypovolemia or not enough volume is gonna be our fluid volume deficit. Good. Yeah, that's true for all of our electrolytes. Your process of elimination, you could probably figure it out. Okay, so anti-diuretic hormone. So when your body is already in a dehydrated state, your body's gonna release vasopressin, which is like an anti-diuretic hormone, so it's gonna prevent you from excreting and eliminating more fluid to try to maintain that fluid volume as much as you can. Okay, so vasopressin. Okay, so if you made it to the end, it's all of the above. Supports the function of our nerves and muscles, helps maintain that blood pressure because the fluid volume is directly related to the sodium, and so it also regulates our body's fluid balance. Okay, good. We're glad we know Lasix, right? It makes this lesson a lot easier. Okay, so fluid volume excess, you could give a diuretic. Furosemide or Lasix is our main one that we know. Okay, pretty good. Okay, so on Dancitron or Zofran, so that's the one we're gonna do our med sheet on. And again, we'll look at this on Wednesday's class. So on Dancitron or Zofran, it's an antiemetic, so it prevents nausea and vomiting, and then hopefully helps that patient maintain fluid balance. And it is actually in chapter 27, is where you'll find that. Right, and then the other ones we know, potassium chloride is a potassium replacement. We know metoprolol, hydromorphone, or Dilaudid, we haven't talked a whole lot about, but it's a really strong narcotic. It's like 7 times stronger than morphine. It comes in PO and IV, so that one's for pain. Okay, so isotonic is the same concentration as our plasma. That's gonna be our 0.9% sodium chloride or NS, normal saline. 3% is our hypertonic example, and then 0.45 is our hypotonic example. Dextrose is sugar, so that would be for like a hypoglycemic patient that they might need some dextrose. Okay, so if the BUN is elevated, so that means there's a higher than normal concentration of waste products in the blood. They could be dehydrated, so things could be too concentrated there. So fluid retention causing hemodilution, meaning there's more watery substance, like more plasma, they're retaining fluid, their fluid volume excess, so that could result in that low hemoglobin or low H&H that we talked about. Okay, this is what my picture is for. Okay, so we need to know if we give an isotonic solution, there's going to be no change. You know, we're going to put it in the vascular space, our body's going to do with it what needs to be done. There's not going to be an automatic shift. Okay, but if we give a hypotonic solution, that's saying that compared to our cells and our interstitial fluid area, it's less concentrated. So say our cells have all this going on. There's all these little particles in here. And our interstitial has all these particles, but then the fluid that we're infusing just has this much that's going in. It's hypotonic, it's less concentrated. Okay, if you read about osmosis, the water is always gonna cross that barrier to equalize. So this needs to be equalized. So this is less concentrated. So if we administer a hypotonic solution, there's much more concentration in the cells. So to normalize everything, your cells are gonna pull that fluid out of the vascular space into the cells themselves. And so the cell could swell and burst and die. Okay, the opposite of that, if we have our cells, they're looking like this, and we administer a hypertonic solution, so we administer all this, okay? Now to equalize, your vascular space is gonna pull from your cells to normalize and maintain homeostasis. So now these cells could shrivel and shrink and then die. So either way, it's not good, okay? But you wanna be able to know that. If we do isotonic, there's no pulling from the cells or pulling into the cells. If we're doing hypotonic, it's gonna pull into the cells. If we're doing hypertonic, it's gonna pull out of the cells. Okay, so there's that's in your reading, and there's some videos and stuff. So just make sure once you get a handle on that, it sticks. But that's something that's hard for students to get a handle on. So, but make sure you'll for sure have a question about we give this solution. Does it pull into or pull out of the cell? Okay, so these terms you all want to know, they could be on your exam. So even though we're not giving fluids yet or starting IVs yet, our patients are getting them, and we need to know what's connected to them and follow through and make sure it's the right rate. And as you saw on your homework guide, every hour we need to assess and chart that we assess their IV status, and we're looking for these complications. So a palpable cord, so it's like hardened and firm, is phlebitis. So that vein itself is inflamed and irritated. Inflammation would just mean like swelling that you could see of that site. Infiltration would mean like when you're looking at their IV site and it's swelling and it's cold to the touch, it means that that fluid is no longer just infusing in the vein, it's infiltrated, it's gotten out of the vein, so it's leaking into the surrounding tissues. Extravasation is infiltration that occurs with a specific type of medication like chemotherapy or some antibiotics. So just like when saline infiltrates, it's painful and we need to catch it right away, it's a pain in the butt, but it's not gonna cause that tissue to die. If we infiltrate chemo or some antibiotics, it's called extravasation, and we need to stop it immediately, just like with the infiltration. Sometimes depending on the drug, there's antidotes, and there's a book of those at your nurse's station. So we'll take the specific antidote and inject it subcutaneously around that infiltrated site, because those drugs will cause tissue death. So they'll turn black and that area will die and they'll have a wound there. So that's extravasation. All right? I'm just gonna keep you in here until 10 after, so you can work on your on Dancitron, or you can work on your 2 med sheets from yesterday. I need to go get my Kahoot prize bucket, because I didn't bring that in here.